and welcome to today's webinar. Thank you very much for taking time out and being here today. My name is Ah-Young. I am the Marketing and Educational Seminar Coordinator here at New Biotech. And today's hello and welcome again. So today's agenda, it's very simple. I will introduce our topic and the presenter, and also I will go over some communication tools, and at the end, I will make an announcement in regard to upcoming webinar, and also watch previous webinars, and also how to receive your C credits. So please don't leave and stay until the end. And today's topic is the Welcome to the World of Successful Implant Dentistry with Dr. Dennis Smiler. And we are also strongly recommended to use the chat box during the webinar to communicate with me. And at the end of this webinar, we will have a Q&A session. So please submit your questions through the Q&A box. And one thing that I want to address is that Dr. Smiler may not answer all of your questions since we have a short period of time. And let's have Dr. Smiler to start the webinar. Good morning, Dr. Smiler. Good morning, Dr. Smiler.
Good. Here we are. How's that? Good morning.
Great.
Everything okay on your end? So, I guess we're ready to start. Well, welcome to the world of successful implant dentistry. And good morning, and thank you for taking your time to attend this seminar. No matter what implant system you currently use in your practice, there are some non-negotiable concepts that contribute to success, and if not adhered to, will hasten failure. So I'm an oral and maxillofacial surgeon. I've been around for a while teaching, developing some training programs from the 1970s and on up to the 1980s. Been very active in the ICOI and the AID, and still have maintained a private practice as well as doing teaching for implant dentistry. So the first thing to realize is that implant dentistry is a prosthetic modality with a surgical component. As an oral surgeon, I would like to think that I am the most important member of the implant team. However, as we all know, this is not the case. The most important member is the restorative dentist. The process of learning any discipline, and especially implant dentistry, involves understanding of the theoretical in combination with hands-on practice. Implant dentistry is not a spectator sport. Learning the art and science of implant dentistry takes time and it takes patience. With this webinar, my plan is to blend the theoretical with practical skills. This becomes the quintessence of knowledge as you master the art of implant dentistry. So let's get started. I begin with 4 non-negotiable concepts that must be well thought out before proceeding with treatment. Cacellous versus cortical bone, biologic width and biotype, biomechanical considerations, design of the surface, treatment, and immediate loading with the Biotech implant. Obviously, each one of these categories or topics is worthy of a lecture in and of itself, so I'll try to then combine what I think are the most salient parts in the presentation. Important, cancellous bone versus cortical bone. When teeth are extracted, there is an immediate reaction of osteoclasts and other inflammatory cells that influence healing, as well as the potential of loss of alveolar bone. It is well established in the literature that in the first few months following tooth extraction, more than 2 to 3 millimeters of ridge height and 4 to 5 millimeters in width may be permanently lost due to resorptive nature of the healing process. The permanent loss of this supporting alveolar bone is not easily replaced and has severe consequences in terms of implant restorations. We know that bone loss can be reduced by socket grafting and or placing an appropriate implant. The rate of remodeling of this bone loss is not uniform from site to site. Since remodeling is a surface phenomenon, and since trabecular bone has a much greater surface area than cortical bone, the metabolic rate, or rate of remodeling, is more than 6 times greater in trabecular bone than what we see in cortical bone. So before I place any implants or do a bone grafting procedure, I want to look at the quality and the quantity of bone at the recipient site. If a bone graft is needed and there is enough quantity of cancellous bone, my preference is to place an intrapositional graft. On the other hand, if the cortical bone predominates, then my preference is to do an onlay graft. Important slide. This is just a representation of cortical bone. You see the lamellae, these are just layers of cells, osteocytes within the lacunae. The inorganic matrix is all of hydroxyapatite, as it is in all mammals. And the organic component is type 1 collagen, glycosaminoglycans, osteonectin, and lots of other proteins. In the cancellous compartment, we have the trabeculi that are loaded with osteoblasts, osteoclasts, and blood vessels. So this is an important slide. This is probably one of the most important that I could see in understanding implant dentistry. It deals with the recipient site. The periosteum is responsible for only about 30% of healing, and this is in a younger patient. If you're doing an onlay graft and you have to fillet the periosteum or do anything to damage the periosteum, then this is going to be reduced. The osteocytes in the cortical bone are the end stage of osteogenesis and only contribute to nourishment of the bone and at a minimum about 10% for bone healing. It is the marrow and the endosteum that contributes about 60% to implant and bone graft success. As this compartment decreases, so does the success of implants and bone grafts. So if we look at a slide that shows us a representation of good, nice, healthy bone, we see that there is a nice area of periosteum, definite area of cortical bone, and a large cancellous compartment of that in the trabecular. But we now know from the previous little slides that we showed before that the resorption is more active in the trabecular bone than we see in the cortical bone. So as the resorption continues, that cancellous compartment gets less and less. And as it gets less and less, so this now becomes a difficult procedure to do implants and or to do any kind of grafting material. Now, eventually, if I have a bone graft or a bone morphology that looks something like this is an extremely difficult procedure, to do. Quite frankly, I try to find somebody in the neighborhood that I don't like and then send them this case, because this is almost an impossible case to do. The concept of biologic width describes the barrier between connective tissue and the implant surface. The understanding that there are specific biotypes is also necessary for success of implant-supported restorations, and we'll talk about this as the slides go on. There are various causes of implant failure: violation of the biologic width, quality, quantity of bone, microgap, surgical trauma, infection, occlusal overloading can be all combined in order to give us a less than successful approach to doing our implants. In my opinion, though, If the cancellous bone is adequate, the cortical bone is adequate. It is the micro gap between the implant and abutment and the violation of the biologic width that hastens implant failure. And the problem is that implants only replicate a natural tooth. The implant mucosa bone interface only approximates the natural periosteum. There is no cementum or periodontal ligament around an implant. There is less vasculature around the implant. And the supracrestal connective tissue does not insert into the implant. Instead, this attachment is circumferentially around the implant. So we can begin with a discussion of biologic width. A tooth is rooted inside the alveolar bone, and it also penetrates through soft tissue into the oral cavity. Some sort of seal mechanism is required to prevent the invasion of bacteria and endotoxins from the mouth into bone. The biologic width assures that there is an approximate 2 to 3 millimeter seal extending from the base of the dental sulcus to the crest of the marginal bone. This is not a new concept. I'm sure I learned this in dental school. I'm sure you probably learned it also. And that we learned about biologic width and biotype in schools, in dental school. But Ingber and Rose were one of the first authors in 1977 to address this concept. And later, Fetty wrote about this in an informative syllabus that was published in 1985. Although neither author addressed how this concept applies to dental implants, the concept still holds because the body always wants to establish the biologic attachment zone between the implant and the alveolar bone. In restorative dentistry, if a filling or a crown restoration is too close to the epithelial attachment, the body reestablishes the biologic width further down on the tooth by lengthening the sulcus and lowering the epithelium and connective tissue attachments. The term biologic width is often used interchangeably with dentogingival junction. However, the phenomenon is different because the implant is only a biocompatible analog and a tooth is a biologic entity. So what are the differences of biologic width between an implant and a natural tooth? The attached gingiva is similar, as is the free gingival margin. The histologic lining of the sulcus is similar, but for the fact that the ready pegs associated with an implant are a little shorter than those of a tooth. The epithelial cells in the sulcus are similar. However, notice that with a tooth, the supracrestal connective tissue attachment is into the tooth and is situated above and below the alveolar crest. There is no connective tissue attachment to an implant. The connective tissue fibers run parallel and circumferentially around the implant and are always below the micro gap when you're using a flat top implant. With a natural tooth, the dentist would not place the margin of a crown restoration below the alveolar bone. If this were done, bone would resorb to a level below the crown margin, thus reestablishing the zone of biologic width. With a flat top collar implant, the amount of remodeling necessary to provide the biologic width requirement is influenced by the position of the implant relative to the alveolar bone. Placing the bottom of the collar supracrestal to the alveolar bone is one technique, Another is to place the top of the implant collar to the above the bone crest. If the implant is placed below the alveolar crest, bone will always resort to reestablish the zone of the dental implant gingival junction. However, with the design of the Biotech implant with its sloping shoulders at the coronal region, we have a success. This combined with platform switching, that we can place that implant about 1 millimeter below the bone crest without bone resorption. To further compound the issue, as seen in this electron microscopic image, the gap between an abutment and a flat top implant, there is always a space. No matter how we torque down the abutment to the flat top implant, there is always a gap. And to a bacteria, this is a Grand Canyon for the development of microtoxins. When an implant without the Biotech coronal sloping shoulder is placed, there is also a gap between the abutment and the implant with loading. As you can see on the slide, circled in red. Notice here that there is this epulis at the margin of where the implant and the abutment was placed in this upper lateral incisor tooth. This is present because the implant was placed below the level of the bone. The body wanted to reestablish the biologic width. It did so by resorbing tissue and bone, thus opening up the way for this type of microtoxins and infection. So maintaining the papilla is also a very important concept in aesthetic restorations. Bone supports the soft tissue and has influence in maintaining the interdental papilla. The gingival tissue usually will form a papilla if the distance between the contact point of the teeth and the marginal bone is about 5 millimeters or less. Notice the coronal design of the Biotech implant with its sloping shoulder, permitting the implant again to be placed about 1 millimeter below crest of bone. This, in addition, as we mentioned, platform switching, produces a thicker anatomic cuff of tissue of gingiva. As described by Nozawa and others, there is a ratio between the horizontal support tissue and vertical support of the sulcus. The ratio is about 1 to 1.5. That is, there is 1.5 millimeter of horizontal gingival tissue to support about 1 millimeter of vertical bone height. So paying attention to these details gives us the opportunity to produce an implant-supported functional and aesthetic restoration. A discussion of the biotype at the implant receptor site is important if we are to deliver an aesthetic as well as a functional restoration. There is that saying that we have, is that bone sets the tone, but tissue is really the issue. So let's look at this. This is beautiful aesthetics, and we can see that it's divided in two parts: an aesthetic restoration of teeth and implants, and the gingiva. Tooth aesthetics are important by the implants, or they're supported by the implants. And the gingival aesthetics is influenced by the biotype. Which biotype is ideal for an implant-supported restoration? And also, which biotype is the worst foundation for an implant? The best biotype for an implant is one where there is thick bone and thick tissue. This biotype provides excellent bone and soft tissue support for the implant. But what about the biotype that has thick bone and thin tissue? The bone width is thick and the soft tissue covering the area is very thin. We see this biotype is more usual in the posterior maxilla, and we also see this type of biotype in the anterior or in the posterior region of the mandible, as we'll see on this slide. So it's the same scenario in the posterior mandible with having then thick tissue with very thin, or thick bone with thin tissue. The biotype of thick tissue and thin bone can be converted to a better biotype after a bone grafting procedure. But what about the biotype of thin bone and thin tissue? This is the worst biotype in which to place an implant, as it often leads to gingival recession and bone loss. Although tissue grafts and bone grafts are a possibility, the success rate is marginal and should only be attempted by really the most experienced clinician. Note here that there is gingival recession on the labial aspect of the lateral incisor. Although the bone may look stable around the implant, the peri-implant tissue contracts and recedes. And this is only because of one of the contributive reasons is the thin bone and thin tissue, a very negative type of biotype. The biotype of thin bone and thin tissue is best treated maybe with soft tissue grafting. This may change the biotype into a thick tissue with thin bone and provides the possibility of a bone grafting procedure, but it's very marginal in its success rate. Briefly, let's discuss a little bit about the biomechanics. What are the basic biomechanical factors needed for implant success? If you understand this slide, you understand everything about implant dentistry. Stress equals force divided by area. To reduce the stress, we either reduce the forces of occlusion and increase the surface area. There's two ways to increase the surface area. One is the size of the diameter of the implant, and the other is the length of the implant. Now, what's important about this slide is that it influences the forces that are going to be placed on the occlusion of the implant-supported restoration. Now, the dentist does have control over some of these parameters, as with prosthetic material to use on the crown, the amount of force, the position. Usually, as what I was taught by Dr. Charlie English, who is a prosthodontist and a good friend and a lecturer, is that the best occlusion is a centric holding cusp into a relatively flat plane occlusion. The importance of this is that stresses are transferred from the restoration to the abutment and then to the abutment implant interface. And this can cause bone resorption as well as screw loosening. But why is there no screw loosening with the NeoBiotech system in implant? There is an accurate fit of the abutment to the implant with no spacing between these components. And we can see this on this slide, the accuracy of the abutment implant interface. And that is the reason why this collection of x-rays shows very, very good bone support, You see the sloping shoulder and a very nice restorative case. The other principle, one that I think is extremely important, especially in crown and bridge, is deflection of the beam. In engineering, deflection is the degree to which a structural element is displaced under a load, like a bridge or a long span bridge. The deflection of the beam increases by the cube of the length. Quite simply, what this means is that a 2-pontic bridge deflects 8 times greater than a single pontic bridge, and a 3-pontic bridge deflects about 27 times greater. So the long span implant supported restoration places stresses on the implant abutment interface, to the adjacent bone, and to the bone implant contact, and this can lead then to implant failure. In addition to the length of the beam that we have on the superstructure is also the width or the depth. The deflection of the beam here is inversely proportional to the cube of the depth. Simply put, as the depth of the framework decreases, there is an increase in framework deflection, which is putting stresses on the implant. So you can see the worst scenario would be a very, very small framework in depth and a long span bridge to be very detrimental to the implant. The other question that we gave some rise to is, what is the importance of the width of the implant versus the length of the implant? What's more important, width or length? Well, if we start off with an implant that is 5 millimeters by 6 millimeters, there is about 114 cubic millimeters of surface area. If we keep the diameter of the implant the same and increase the length by 1 millimeter, there's a 14% increase in surface area. Keeping the length and the same is increasing the width by 1 millimeter provides a 24% increase in surface area. So width is important for long-term success and retention of bone support. However, we must be cognizant that if the diameter of the implant encroaches on the thin crestal cortical bone, this pressure will produce bone resorption. To counter this, it is suggested to have about a millimeter and a half of bone circumferentially around the implant. 1.5 millimeters of bone circumferentially around the implant puts little pressure on the crestal bone. If you have less than 1.5 millimeters of bone, this encroaches on the cortical region and can produce bone resorption. So when I am picking an implant, I'm looking at my CT scan, and I want to see what is the diameter of the implant that I'm going to place that gives me enough bone circumferentially around that implant. In this study of a 5-year survival rate, was one keeping 1.5 millimeters of bone around the implant, there was a 96.8% success rate. Using a wider implant with less than 1.5 of bone around the implant, the survival rate was about 81%. This is a failure rate of almost 16%. And the reason for this is only because not keeping enough bone circumferentially around the implant. So when you're picking an implant, no matter what system you're using, it is most important that you at least have a millimeter and a half of bone around the implant. And we can certainly determine this on preoperative CT scans. What is the key to initial biomechanical integration of the implant that's going to lead us to osseointegration? We're going to take these 3 concepts of design, implant design, fixation design, and surface design to explain the importance of each. The major challenge for contemporary dental implantologists is to provide oral rehabilitation to patients that are asking for rapid loading protocols or to patients with compromised bone. And the implant design is especially important to deliver a very biocompatible implant. As we see here, there's approximately 1,300, as of today's webinar, different implant systems. Surface characteristics like structure, wettability, and coatings contribute to the biologic processes during osseointegration by mediating the direct interaction of host osteoblasts in bone formation. So what happens at the implant bone interface immediately after placing or insertion? There is an effect of granulocytic macrophages, precursors found in bone marrow. They enter the circulation as monocytes, and through asynchronous fusion, they produce a multinucleated giant cell as the precursor to an osteoclast. Morphologically, the multinucleated giant cell attaches to bone and displays the physiologic role of an osteoclast-mediated bone resorption. So this is resorption between the implant and bone. And then the reciprocal interaction between osteoblasts and osteoclasts energizes the cellular dynamics, and the process of bone formation begins. We see here there are fibrils that are forming a network upon which the osteoblast is going to attach to the implant. The result is an interface attachment of woven bone to the implant. Woven bone is the first type of bone that's going to be attached and developed around the implant, and this will change into a lamellar bone under physiologic loading and mineralization of the woven bone. It should be mentioned that the mineralization process can take up to 4 to 6 months. So the interaction of the initial stability of the implant to bone is vitally important for long-term success. The design concept of the Neobiotech implant is unique. There is that 0.5 millimeter of bioseal to increase the sealing of soft tissue to the implant. The coronal macro thread provides excellent primary stability. The threads at the body of the implant are designed to withstand occlusal and lateral loading conditions. At the apex of the implant, the thread design provides stability for immediate placement and immediate loading. Most of my cases, actually practically all of my cases, are with the Neobiotech IS2. This is a kit that we've been using, but I know there are more advanced kits and newer design kits that are available. Fixation design of the Neobiotech implant improves bone implant contact, or BIC. This is accomplished by bone compaction during placement that provides initial immobilization. And the concept is developed for this immobilization by the concept of CMI. Implant immobilization is the key to osseointegration. And this is accomplished with that concept of CMI. C is at the region of crestal bone for bone implant contact, M for the mid-implant threads, and I referring to a thread design at the apex of the implant. The bone implant contact increases with bone compaction while inserting the implant. An important concept which we'll show in the next few slides. With type 1 or type 2 bone, remember this is very dense bone with a very small cortical area, crestal cortical region. Most of the stress is at the juncture of the cortical bone and the implant. The CMI concept and its immobilization helps to ameliorate this problem. To address this point, I refer to a study that was comparing a Straumann implant to a Biotech IS2 active implant. The study compared early loading of splinted implants supporting a 2-unit fixed restoration. After 13 months, there was enhanced primary stability with the Biotech implant compared with a straight-walled Straumann implant. And the reason for this, or one of the reasons for this, is bone compaction. By under-drilling the implant site, there is self-compaction within the cancellous bone when the implant is placed, and then there is increase in the bone implant contact, or BIC. Placing the implant can be with delay loading, where there is full drilling and self-tapping, or with countersinking the implant and then self-compaction, or, as with any time loading, pre-tapping the cortical bone and then self-compacting the cancellous bone. And this animation shows the self-compaction in this D4 bone. It has a very thin cortical plate. The site is under-drilled to a 2.9 millimeter that will accommodate a 4 millimeter diameter implant. To establish ideal CMI fixation in D1 or D2 bone, there is pre-tapping in the cortical bone and self-compaction within the cancellous bone. Preparation for a 4 by 10 millimeter implant begins with the 3.5 drill to the full length, followed by the 2.9 drill. The 3.4 drill is only through the dense cortical bone, and then the cortical bone is pre-tapped with a 4 millimeter short tap. The cancellous bone is under-drilled to 3.4 millimeters for a 4 millimeter diameter implant. And then the threads of the profile tap fit the threads of the implant. The profile tap prepares the cortical bone so that there is intimate contact between bone and the implant surface. This provides increased bone implant contact than an implant that is countersunk. So using a tap rather than countersinking will increase the bone implant contact. For any time loading in D1 or D2 bone, sequential drilling to a 3.5 or 3.4 millimeter drill prepares the full extent of the receptor site. 4 millimeter long tap has its path through cortical and cancellous bone. And then a 4 millimeter short tap prepares the cortical bone. As a result, there is intimate contact, bone implant contact within the cortical bone. However, with this, as you see, there is no compaction of the cancellous compartment. Now, depending on the torque value of placing the implant, we'll decide whether or not we're going to be placing a cap screw and letting it heal, putting on a healing abutment, or placing crown restoration for immediate load. So if I am placing an implant and the torque value is 10 to 20 Newton centimeters, I'll usually submerge the implant, let it heal, and come back later to put on the healing abutment. If I'm up around 20 to 30 Newton centimeters, then I'm going to place a healing abutment. And if I'm at 30 to 40, this is enough stability and enough torque in order for immediate loading. However, do not exceed 40 Newton centimeters. We see again with type 1 or type 2 bone, most of the stresses is at the juncture of cortical bone and the implant. And those stresses can give us bone resorption. Crestal cortical bone is thin. It has a deficient blood supply, as we noted, and it is composed mostly of osteocytes. And remember that the osteocytes were the end stage of osteogenesis, and they contribute very little to repair. So if there is overcompaction at that C fixation area, bone will resorb. Now a little bit to talk about surface design and its contribution to bone implant contact, which is going to give us the ability for immediate loading. The concept of implant design, fixation, and the surface treatment that we see on an implant. Preparation at the implant site is like the fracture of bone. The healing process produces a dynamic state of cellular activity. There is activation of platelets and leukocytes, attachment of proteins or fibrils that attach to the surface of the implant, and the retention of these proteins, these fibrils. They support osteogenic cells on the implant surface, which is all dependent on the surface topography. Surface characteristics like topography, wettability, coatings contribute to the biologic process during osseointegration by mediating the direct interaction of host osteoblasts to bone formation. By increasing surface roughness, there is potential increase of bone implant contact. The degree of surface roughness varies with various implant systems. Some use a machine surface, some were using grit blast, some acid etch, and some in previous times using plasma spray, either with titanium or, as we saw previously, with hydroxyapatite. The important factor for an implant, then, is its surface capacity for being anchored in the bone. And this is related to the surface roughness. If they have an increased amount of roughness, there is the greater possibility of bone implant contact. We see that a roughened surface is going to give us greater than, say, 2 to 3 microns of roughness as compared to a smooth surface. Bone anchorage with the machine surface implant is not ideal. A plasma spray surface on the implant is also not ideal, as an excessively macro rough surface permits overabundance of giant cells and macrophages. That turns in, as remember, to osteoclasts with the ability to phagocytize portions of the implant surface and the bone. So the bone implant contact depends on the surface characteristics of the implant. And we now know that there is a 50% increase in bone implant contact with the surface that is a micro rough when compared to machine surfaces. And in this slide, we see that there is a comparison between an acid etch surface and a machine surface, showing increased bone implant contact with the acid etch surface. The second generation of surface modifications that are done with implants are titanium grit blasted, electrolytically enhanced surfaces, sandblast surface, or an acid etch surface. These are all designed to produce a micro rough surface on the implant. For many years, dental implants have been successful with sandblasting, acid etching, and any other hydrophilic surface textures. It appears that the best implant surface, it's a combination of sandblasting and acid etch surface, or what we call now the SLA surface, producing a surface roughness of about 0.5 to 3 microns. So the micro rough surface effectively can capture and retain the fiber and clot initially deposited on the implant surface. As a result, the initial critical events of plasma protein absorption, clot formation, angiogenesis, mesenchymal cell migration, and osseointegration are all facilitated. The first generation of surface treatment on the Biotech system was RBM, or resorbable blast media. Today, each Biotech implant is individually treated with the SLA technique that improves surface roughness and therefore bone implant contact. So this shows how that implant is now sprayed in order to increase the surface roughness, which is then going to allow the fibrils attached to the implant surface that's going to help us with bone formation. Once the surface roughness is increased, we're going to add then acid etching. So the SLA surface is a combination of the sandblasting and also the acid etching. And the SLA surface on an active implant is now, I think, the new standard that we're going to be using in implant dentistry. It's time to talk about what we refer to as the stability dip of the implant as it proceeds to osseointegration. The process of osseointegration is divided into 3 phases: mechanical stability, primary stability, and secondary stability. Mechanical stability is after insertion, and it's due to the friction between the implant and bone and is dependent on the surface topography. The transition from mechanical to primary stability begins almost immediately. This process can continue up to 3 to 6 weeks, during which the implant is less stable than when it was initially placed. This is the stability dip. Secondary stability follows when there is osteoblastic activity to lay down new bone. Because of the stability dip, there is a no loading zone that can extend up to about 6 weeks following placement of the implant. But with the SLA surface on the Biotech implants, there is a 60% more bone implant contact after only 2 weeks. This earlier formation of more mature bone significantly reduces the stability dip. The blue line shows the percentage of bone implant contact without the SLA surface, and the purple line on top is with the SLA surface and shows a higher percentage of bone implant contact in a shorter time frame. The aim is to flatten and reduce the stability curve. Look at the purple line at the top of the graph. It begins with maximum bone implant contact on day 1 and continues over the 4 to 14 weeks of healing. Bone compaction during placement, the CMI concept, thread design, the SLA surface, all combine to provide implant immobilization with maximum bone implant contact. So the stability dip curve is flattened, and the Biotech implant is ready for anytime loading. So now that we've done a lot of comparing the theoretical with the practical, let me just discuss about 2 or 3 cases to put a clinical touch on the webinar before we close. Normally, we're going to see in placing an implant, the pilot hole. This is an older design of the drill with a stopper. It's yellow, so I know this is 10 millimeters, and it's going to allow me to do the drilling, but not to exceed 10 millimeters in depth. We're going to do the drilling with sequential drilling. This is up to a 4.5 millimeter implant. And if we're placing wider, this is now going to be with a 5 millimeter drill for that 5 millimeter diameter implant. Drill down to the depth, and then the bone is tapped. Remember, this is probably the bone biotype of thick bone with thin tissue. That tap is now going to give us the thread design that we see here in the bone that will be the intimate contact of the implant to bone. Before placing an implant, my preference is to wet the implant, making a hydrophilic surface, and then place the implant. Using the torque wrench to give me the amount of Newton centimeters. That will determine whether or not I want to place the implant for primary loading, or if I want to do a healing abutment and then come back at a second visit after suture removal with the healing abutment. Let that heal for 3 to 4 weeks. Refer back to the dentist for prosthetic reconstruction and for a nice crown restoration. Notice on this x-ray, sloping shoulder, platform switching, and the thread design, all designed to give us the bone implant contact that we need for stabilization and osseointegration. If I have a tooth that is broken, decayed, especially in the molar area, I have problems placing that implant where the bifurcation would be, and that because that bone is very thin. So my preference is to either cut the crown off, break it, but do the sequential drilling starting at the bifurcation, leaving the mesial and distal roots in place. Prepare the implant site. Now I have the implant site prepared. I can put in an elevator on either side and remove the mesial and the distal root. Bone grafting can continue, and we can place an implant, in this case, a little bit more graft around the circumference, the crestal region, and the site was sutured. Here we have a molar tooth that's going to be removed. There's a lot of bone loss, some excessive periodontal ligament, and probably an abscess infection in the bone. The tooth is extracted, mucoperiosteal flap, sequential drilling, placing with parallel pins, and here placing implants. 3 implants are placed. Notice that there is bone loss, a defect around this implant. That will be grafted with a sticky bone, which is a combination of an alveolar allograft in combination with concentrated growth factors, or PRP. This is placed over the implant. The mucoperiosteal flap is repositioned and sutured. After healing with the healing abutments, it returns back to the dentist. And this is 2 weeks for the impression. The dentist does the restorative aspect. And here we see the implant restoration at 3 weeks. Now this was done in 2007. And if we look at the same case in 2014, we can see that there is good crystal bone. We see the sloping shoulders, and we see there's excellent bone implant contact. This is an interesting case because it shows that there is the hissance of that labial plate of bone. Now you can still place the implant, but the implant has to be within the confines of the cancellous compartment. If the implant is wide and comes out of that cortical bone, then that's going to be a failure. So the implant site is prepared. The implant is situated in place, Biotech, so it's quite stable. Healing abutment is going to be his position, and on top of that, we'll do a graft. This will work again if that implant is within the cancellous compartment. Outside the cancellous compartment, the graft and the implant will not work. So here a membrane is placed and the area is sutured. Here we see that this is a central incisor. The tooth is extracted, gives us the length of the implant that we're going to place, and we're going to make sure placing the implant is more to the palatal, so we leave about 3 or 4 millimeters of labial bone intact. So going from March 25th with the healing abutment, the 10th to the 7th, and by the 21st of June, the patient now has nice crown restoration. There is the platform switching and a very successful case. The other thing I like to do in thin cases, thin bone, alveolar bone in the maxilla of the mandible, is tissue or bone spreading. And this is just a case of bone spreading with a piezo saw. So I'll first put a little opening of where I want the implants to go, and if it's a 10 millimeter long implant, that piezo saw has to go down 10 millimeters, the whole length of where the implants are going to be placed. And the secret to this and spreading the bone is not to be too aggressive. You put the implant in, you let it sit for maybe a minute after 2 or 3 threads are there, then another 2 or 3 threads, let that relax the bone until the implant is firmly inside. So you can go from this to this. But the slower you go, the faster you get there. So be very careful and not to do that too quickly. Then bone graft on top. This is in the posterior maxilla. Same concept. And we can talk about the procedure for this maybe at another webinar. We have good, there's a nice bone graft, there's an implant placement, and we're going to have a successful result. So when I come back in these cases and put on the healing abutment, I have no problem leaving a little space between the gingival margins because that's going to fill in with more attached keratinized tissue. And now we have the final case. So I want to very much thank you for your attention for this webinar. And I will take some questions, but if we run out of time, you could email me at smiler@smiler.net or go to the web page as you see on the screen, and I'll be there to answer any questions. So I think we're finished. Let's see if we have any questions. It looks like everything has been well explained. So thank you very much, and I'm going to end the webinar.
Thank you very much, Doctor, for your presentations. And now looks like I will make an announcement. Here you go. So if you are interested in taking our webinars, you can find upcoming webinars in our website at www.neobiotechusa.com and click the webinar at the top, then you'll be on our webinar page. And we will have a second webinar today at 2 p.m. Pacific Coast time with Dr. Spencer Park on topic of how do you like your implant stability here. So, and we also have announced a special promotion during this webinar, so don't miss out. And starting this week, we will have 2 webinars every Monday and Thursday. So total 4 webinars weekly, and the day is Monday and Thursday, 1 in the morning from 11 to 2, 11 to 12, and 1 in the afternoon from 2 to 3 p.m. It's all Pacific Coast time. And all these courses are on first come, first served basis, so please register in advance and reserve your spot. So for Dr. Smiler's upcoming webinars are on Monday, May 25th at 2 p.m. on the planning and surgery for extramaxillary zygoma implants, part 1, and the part 2 will be on Thursday, May 28th at 11 a.m. So please also save the dates and mark on your calendar. We also have a great lecture coming up next week on Monday with Dr. Ken Huang on sinus leak and at 2 p.m. with Dr. Lara on implant complication and failure, and on Thursday at 11 with Dr. Owen Train on anterior implant, and lastly on Thursday, May 14th with Dr. Jeffrey Platt on advanced bone grafting. And here are more added webinars. I will not go over everything, but you will see all these added webinars on our website here at www.neobiotechusa.com. And now you can watch our previous webinars on our website. Just click the previous webinars at the top, and please be advised that we do not promote for watching recorded webinars, but you can feel free to come and check out all these previous webinars. And here is the CE, and I want to say thank you very much for those who stay until the end. And as part of our ongoing effort to provide better continuing education courses, we would like to request your feedback via a short course evaluation. And one of our sales reps will email you this link. So once you receive it, please fill it out and submit it as soon as possible. And this form should take no longer than 5 minutes to complete. It's very easy. And also please, here's more questions in the bottom, and the form should look something like this here. And I want to say thank you again for participating in today's webinar. And we really hope to see you again next time. So don't forget to register on our website, and also please feel free to contact me if you have any questions, and also if you have any questions about the lecture today, feel free also to email Dr. Smiler. And thank you very much, Dr. Smiler, as well.
You're very welcome.
All right, thank you very much, and hope everyone will have a wonderful day.